I see a mixture of patients in clinic, and I think that that to some degree is a reflection of what it is that we do at the University of Michigan, that I'll serve as a general cardiologist as much as anybody is a general cardiologist, but because of my interest in heart valve disease, I'll end up seeing an increased number of patients that have heart valve problems. And I may not be the first cardiologist who they're seeing. I may be the second or the third cardiologist they're seeing to get another opinion or to help somebody with a problem that someone else hasn't been able to help with. I like as much as I can in taking care of patients to try to individualize decision-making with an individual patient. I think we're bombarded in a way with a lot of information in patient care these days. And maybe the easiest thing to do is just to follow the rules, follow the guidelines, check boxes and fit people in pigeonholes and then use testing and therapy according to that. But I try as much as I can to bring expertise and experience to patients to educate the patient and then basically help them make a decision about how they want to guide their care. One of the things that I try to do in seeing patients in clinic is to be as comprehensive in any one clinic visit as I can. So if a patient is seeing me for the first time, I'll try to review tests ahead of time if I have access to them or at the time that they're in clinic. But also if they need additional testing, I have access to being able to do a lot of that while the patient is in clinic. And in some ways it may turn into 2 clinic visits where I see a patient, talk to them, examine them, and then send them down the hall for some tests, look at the tests, and then we sit back down together and talk about the results of the tests and try to, as much as possible, bring a package of where the patient is at this point and where to go from there.